Hello and welcome to Healthcare Career and Focus session today. So in celebration of Healthcare Science Week, we have Callum who's going to talk to us today about being a student healthcare scientist. So over to you, Callum.
Hello guys, my name's Callum. I'm a student healthcare scientist and I work at West Suffolk Hospital in Diagnostic Cardiology. So I'll just go into a little background about me. So my career journey so far, so I studied as an undergraduate in sport and exercise science at Northern Michigan University in America. So I was on a football scholarship there for 4 years. Came back following the COVID-19 pandemic, and I started working in cardiology on the bank team. The team here basically offered me some training to begin with, just to learn the sort of foundations, and then they offered me a progression post, which involved completing the healthcare science practitioner degree apprenticeship, which I started in 2022. So I'm currently in my third year, which is obviously pretty crazy because it's gone so quick. And from when I started, I've obviously developed so much, and yeah, it's really like helpful for my sort of career moving forward. So yeah, I'm working in diagnostic cardiology, developing clinical and professional skills. So a couple photos there showing how quickly it can change. Obviously, playing football in a snowstorm in Michigan to working in a cath lab in West Suffolk. So a day in the life of a cardiology healthcare scientist. So we start sort of learning from the bottom, which is the foundations of sort of ECGs. So we have a ECG clinic, which is a walk-in clinic, and we'll complete 12 lead ECGs for clinics sort of all around the hospital. So we'll have referrals from heart failure, consultant-led clinics. They'll send patients down for ECGs, just sort of follow up ECGs. It can be diagnostic. So yeah, that's a very busy clinic and a good way to sort of begin within cardiology. Similar to that, we have ambulatory blood pressure and ECG monitoring. So those are monitors which patients will take home. They'll wear them for upwards of 24 hours, just to make sure there's no sort of changes seen throughout the day, throughout the night. Sometimes we can put these monitors on people for longer if there's sort of clinical reasons for it. But again, that's quite sort of foundation level, sort of where I started to begin with. So following from that, analysing ECG recordings. So when those monitors come back to us in the department, we have a software which we plug it into, and we'll get the ECG recordings. We'll go through it, look for any arrhythmias, any abnormalities. We'll then sort of decide how we need to flag this to the consultants, back to the GPs, to make sure that patients obviously get the care that they need. So we have a escalation protocol which we follow pretty closely to make sure that obviously anything urgent is seen straight away, and anything sort of routine can just go back and be followed up accordingly. In my final year, I've sort of started learning the basics of more complex procedures. So that within cardiology, we sort of have an invasive and non-invasive sort of two specialisms. So the invasive side of things, we're looking at obviously pacemaker implants, and cardiac cath, which is where they'll use a catheter to, in terms of looking at the coronary arteries. There's loads of different things they can use catheters for. They can even use sort of for valve implants. So it's again something I've sort of just started doing this year, but it's been really interesting, good experience so far. And non-invasive, we have scans such as echocardiography, which is an ultrasound scan, kind of like a baby scan for the heart. So that's something which, again, I've had a little bit of exposure to this year in my third year, and something hopefully I'll be able to get more experience in as I sort of progress further. And then we'll do other tests such as exercise tolerance tests. So we'll get patients on a treadmill, They'll be connected up to an ECG and blood pressure, and we'll monitor them as they do a walk sort of up a hill. So those are all sorts of things that we'll do sort of day to day in the life of a healthcare scientist in cardiology. So rewards, obviously, there's loads of positives from working within division of healthcare science. Firstly, we have a real positive impact on patients. Within cardiology, especially, we diagnose, we follow up patients, so there's real sort of continuity of care. We'll see the same patients. They'll obviously build a rapport with us, and it's good to obviously kind of follow these patients up and see the impact that sort of our care can have on them. So diverse job roles. As I mentioned, there's different specialisms. There's loads of different procedures that we do that physiologists are involved in, which makes every day different. There's loads of different sort of skills that you need to have and demonstrate day to day. So yeah, it's a really diverse job, which I think in the field at the moment is evolving and always getting more sort of complex and advanced. So in terms of our career progression and opportunities moving forward, it's something that yeah, there's loads of opportunities for physiologists sort of in the future as well. For me, obviously, I'm on an NHS funded program, so getting paid a salary at the same time as being trained. The NHS pay for my training as well. So obviously it's something that isn't possible in other sort of degrees around the country. So obviously being able to come out of this fully qualified with no student debt and things like that is a real positive. Working within our team here at West Suffolk is brilliant. Everyone's amazing. There's so many different levels of experience and skill sets within the team. Even, we have a big admin team. We've got loads of really highly specialized physiologists and all the way down to, our students like me, So there's loads of opportunities to learn, loads of different people that you'll meet and work alongside with. So yeah, especially for someone like me who's come from a sport background, working within teams is something I've always hoped I'd carry forward into my career. So it's yeah, definitely a good positive of working within healthcare science. And obviously it's a very rewarding job. So knowing that you've helped patients day to day, obviously when we follow patients up, we can see the impact that we have on their sort of quality of life. So yeah, knowing that we're making an impact on them in our jobs is really rewarding and a massive positive. So next up, I've got a case study. This is just sort of an example of, I try to use a case study which collaborates non-invasive and invasive cardiology. Again, sort of things I'm early into in my training, but things that I've come across this year. So hopefully this case study will kind of knit together a bit of invasive and non-invasive cardiology. So the case study is a patient with severe aortic stenosis, which is a condition where the aortic valve in the heart becomes sort of calcified, the leaflets become quite stiff, and it can cause a lot of problems. So this patient was an 82-year-old female patient, severe aortic stenosis shown on a recent echocardiogram. She was referred for a coronary angiogram, which falls within cardiac cath, for a TAVI workup, which is it's a aortic valve implant, which is implanted using a catheter. So the background, so obviously the condition was diagnosed via echocardiography. So the results of the patient's echocardiogram showed a calcified aortic valve. This can be seen in the two images. It's difficult to see on the top image, but if you look on the second image, in the middle of the screen, there's sort of that bright white around the valve, which in anything bright white and echo usually means calcium and indicates disease, really. So that's quite a severe case of it. When these images usually are live, so obviously they're moving. When this image was moving, there was not a lot of movement from the valve, which obviously indicates that it's quite stiff from the disease. So this is known as aortic stenosis, which restricts blood flow through the valve. The valve function is important as it allows flow from the left ventricle through the aorta and into systemic circulation. So our left ventricle pumps oxygenated blood all around the body. So it goes out of that valve into the aorta to go to all the rest of the body where it's needed. So obviously quite important that that valve is functioning well. And in this patient, obviously it wasn't. Typically, aortic stenosis will lead to symptoms such as dizziness, shortness of breath, and chest tightness, are all associated with aortic stenosis. So when we go on to the patient's echo results, we'll go into a little bit more detail. So using clinical guidelines set by the BSE, which is the British Society of Echocardiography, we can use loads of numbers to assess the severity of the disease. Many of the parameters of what was measured for this patient fell into moderately diseased, but visually it looked severely diseased. So a lot of echo is kind of assessing the numbers versus what the physiologist deems sort of visually. So most of the numbers fell into the moderate category, apart from the aortic valve area, which was severe and close to being very severe, which definitely lent us into thinking that this was more severe for everything. So we did treat this as a severe case of aortic stenosis, and she was later referred for a TAVI, which was as I mentioned, is a implant to improve the valve's function, and make sure that try and relieve the patient's symptoms. So when we look at the photos, there's the top right is the BSE guidance on aortic stenosis. So based off all the numbers that we get from our echoes, from our scans, we'll be able to assess versus that guidance to kind of decide how severe the disease is. The second photo is just some of the numbers that I was speaking about. So we'd compare those versus the guidance to decide how diseased it is. I've circled a little bit because that will be relevant for my next stage. So keep the 33 in mind. And then the bottom photo is a Doppler from the echo scan, which is another sort of technique used within echo to measure flow through the valve. And it's another way of determining how severe the disease is. So as I mentioned earlier, within cardiology, we have two specialisms of non-invasive and invasive. Obviously, they often combine in patients' treatment pathways to make sure that sort of the best outcomes for the patient. So as a workup for a TAVI, the patient will need an angiogram to just make sure that all of the coronary arteries are unobstructed before they intervene on the valve. Basically, with such important procedures such as valve replacements or TAVIs, if there are other areas of disease, they'd much rather do it all at once, tick all the boxes, and just it just limits the possibilities of complications, infections, things like that. So if there was any coronary artery disease present, they might consider a aortic valve replacement and a coronary artery bypass, just as a whole sort of open heart surgery. But in this case, the patient's coronary arteries were unobstructed, meaning a TAVI was the best choice for treatment. So it's important that we kind of tick all the boxes and build the patient up before having a procedure, so we don't find obviously anything incidentally when we're intervening at such an important part of the patient's care. So I think I was part of this procedure, the angiogram, as part of my training for this year, which is sort of how I came to realise about this patient. So the angiogram results obviously were unobstructed, but there are, as I mentioned earlier, within cardiac cath, there's lots of other sort of techniques we can use to assess loads of different things. And with patients with severe aortic stenosis, usually the valve is so sort of stiff you can't actually get a catheter through it. But in this case, we managed to get the catheter to go through the aorta into the left ventricle. So the two pressure readings on the side there, the top one is the left ventricular pressure. So we know that just because of how big the pressures are. It basically is because the diastolic pressures are really low. The left ventricle completely empties during systole, so we'd expect that pressure to be a lot lower. The bottom pressure is the pressure reading from the aorta, and the systolic pressures are much lower than the systolic pressures in the LV, and that is the pressure gradient. So what I'd circled earlier from the echo results, we had the mean gradient measured at 33, and in the LV pullback, which is this study in front of us, we can basically see that the systolic measurement for the pressure in the LV was 117 and the aortic pressure is 87, which is pretty in line with what we were getting in the echocardiogram, and it's just another way of measuring that pressure gradient across the valve. So it's kind of a nice way to show there's different ways that we can measure gradients across valves. This is a lot more rare, mainly because usually the valve's too diseased for us to complete a study such as this. But as we were working up for this, it was good to be able to see an invasive version of gaining those measurements. So as we work obviously across non-invasive, invasive cardiology, there's a real multidisciplinary approach to working. So the case study highlights the importance of a multidisciplinary approach to cardiac diagnostics. From echocardiography, this patient would have been picked up early in a routine echo. She would have been referred to the valve disease clinic. So we have a more specialized clinic where they really focus on the valve which is diseased, just to make sure they're monitoring the progression of it, sort of assessing it in line with the patient's symptoms before deciding how to proceed with intervention when the patient needs it. A variety of healthcare professionals are involved in the patient's care. So from these clinics, the patient would have had input from the consultants, cardiac nurses, radiographers when working in the cath labs, cardiac physiologists like myself, and all the healthcare assistants that obviously help prepare patients for procedures such as this. And as I mentioned, this case study shows the importance of two different specialisms within cardiology combining to achieve the best possible outcomes for the patient's condition. So the results, the patient was successfully worked up for a TAVI. TAVI procedures are completed at Papworth from West Suffolk, so we'll help prepare them doing the echocardiograms, the angiograms, before transferring their care to Papworth for the procedure itself. The patient will then be back to West Suffolk for follow-up, so we'll sort of surveillance echocardiogram scans to assess the new valve's function. It's hoped that the patient's left ventricle will improve as a result of the new valve. Obviously, there was a lot of strain put on the LV with such a tightly restricted valve. And TAVIs have a high success rate and a very common procedure. So patients often feel that their symptoms alleviate quickly. And we're hoping that when we follow this patient up next, it will be a positive outcome.
Oh, that's great. Thank you so much, Callum. It's really interesting to sort of see the UK study and how you've sort of worked together to help this patient. Lovely. And I think also your story is going to be really inspiring for anybody that is very interested in sports but could see different options, you know, not only going into physiotherapy but also going into healthcare science. So thank you for that, Callum. Thank you everyone for watching. On the screen, you'll see a QR code, and we really welcome your feedback. Thank you very much, and goodbye.